or secondary. Primary means that it is not present in the diet. Secondary means that it is present in the diet, but the body is unable to have access to it, either from intestinal malabsorption, or there's poor transport in the blood, or the storage in the tissue is problematic, or the metabolic conversion. So we move to vitamin A. So vitamin A has several forms, and the most important one is the retinol. And it undergoes oxidation, the aldehyde form, which is retinol, and then it can also be converted into the acid form, which is retinoic acid. We know where we get vitamin A from. We have animal sources, and we also have plant sources. And commonly for the plant sources, the orange or the red are a good source, as well as the green leafy vegetables. So when you take in vitamin A, it is absorbed, it's fat soluble, so it is absorbed into the intestine, from the intestine into the body, and then it goes to be stored in the liver. You have more than 90% of the body vitamin D stored in the liver. That's why the liver is a good source of vitamin A. So the liver can have enough for at least 6 months. And so if the diet is deficient and the patient is showing signs of deficiency of vitamin A, it means that the diet has been deficient of vitamin A for a very long time. So the liver can up to 6 months store of vitamin A. So the main functions of vitamin A are maintenance of normal vision, then helping with the epithelium, preserving the epithelium of specialized cells. That's the mucus secreting cells in the respiratory epithelium. And then enhancement of, please, whoever's, mute your microphones, and there's a lot of feedback coming in. We know that vitamin A also has an antioxidant property. And usually when you have a deficiency, you start off by having night blindness. So patients would complain of impaired vision, especially at night or with reduced light. Then persistently, they'll end up with changes in the eye, the epithelium of the eye, and then they'll end up with bitter spots on the eye, and then the cornea can ulcerate, all as a result of vitamin A deficiency, because the vitamin A helps with the preservation of the epithelium. And so when the vitamin A deficiency is there, it means that the epithelial lining of the eye especially will be affected, and then you end up with all these spots. So it's a transition. So the night blindness is actually an early sign of vitamin A deficiency. Then we also said that one of the functions is for preservation of immunity. And so they end up with common infections, and typically measles and pneumonia are high on the list. Vitamin A is also good for maintaining the integrity of the GIT, and so they have a lot of infectious diarrhea. Now, if you have vitamin A excess, then you end up with vitamin A toxicity. And usually what happens is that, let me say one thing. Toxicity of vitamins usually occurs with the fat-soluble vitamins because they are stored in the fats in the body. However, in contrast, the water-soluble vitamins do not typically give toxicity because when there's excess of it, the rest is lost either in the urine or in the stool, so it doesn't stay in the body. So the clinical consequences of acute vitamin A excess, called hypervitaminosis A, are headache, vomiting, stupor, and papilledema. So in the acute phase, that's what will happen. If the toxicity goes on for a very long time, then the patient manifests with weight loss, nausea, and vomiting. And vitamin A is also toxic to the fetus. And so if you are pregnant, especially first trimester, and you are taking vitamin A supplements, it can be teratogenic and lead to congenital malformations in the fetus. Now, I must say that usually the commonest cause of toxicity of vitamins is excessive supplements. So when you are taking supplements, you have to take cognizance of the recommended dietary allowance. You find it online of any vitamin. They will tell you how much you need in a day, recommended daily allowance. So once you know the amounts you need in a day, you look on the label. If you realize that what you need in a day is excessive, is in excess of what is on the container, then that's fine. But if you realize that what the container supplies in a day is more than what you need, then you're likely to end up with toxicity. So these are important things we need to take cognizance of when we are prescribing vitamins. And in Ghana, we are very fond of giving mojedro for everything.
Mm.
And it's important for us to bear in mind that there are consequences as well. So the supplements that we prescribe, we have to know why we prescribe them, not just because the patient says, I can't eat, so you prescribe supplements. You have to bear that in mind. Patients also have the tendency to go and buy the medication after they've recovered or after they finish taking the course. And so it's also important for us to educate them properly. So we move to vitamin D. The major function of vitamin D is for the maintenance of normal calcium and phosphorus levels, and also for the maintenance of integrity of the bone. So metabolism of vitamin D, the major source of vitamin D is usually the sunlight. It's endogenous production. So when the sun acts on the skin, there's conversion of certain precursors into one of the precursors of vitamin D. It goes to the kidney, it goes to the liver, and completes its conversion till we get the active vitamin D. Now, usually, the amount of vitamin D that you can make from the sun depends on how much melanin you have in your skin and also how much sun exposure you have. And it's been known that black skin has a lot of melanin, and so this prevents the optimum vitamin D conversion in the skin. So even though we have a lot of sunlight and we have a lot of exposure as well, because we do a lot outside, we may not be getting our requisite vitamin D level because we have a lot of melanin in our skin. So when you are not getting enough vitamin D from the skin, then the rest has to come from food. And you have several sources: fish, plants, and grains, and so on. Okay. So usually when you eat a food rich in vitamin D, it is bound to a vitamin D binding protein in the blood called alpha 1 globulin. Now, this alpha 1 globulin will carry it to the liver. The liver will convert it to 25 hydroxyvitamin D. The final conversion occurs in the kidney to 125 dihydroxyvitamin D, and that is the active form. So this is just a diagram showing what happens. So either you take in the vitamin D, maybe through milk, you drink a glass of milk which has a rich source of vitamin D, or the ultraviolet light falls on your skin from the sun and converts a chemical in the skin called 7-dehydrocholesterol in the skin to the first vitamin D precursor. Now, this vitamin D precursor is bound to alpha globulin in the blood and it goes to the liver. When it gets to the liver, you have the 25 hydroxylation in the liver by the enzyme 25 hydroxylase. Yes, yes. So this 25 dehydroxylase would converts the vitamin D into that's it. So when it's converted, then to be sent to the kidneys. Okay, and the kidneys will convert it to 125 vitamin D. And this vitamin D goes to act on the intestine and the bone. In the bone, it helps with bone mineralization, maintaining the integrity of the bone. Then in the intestine, it also increases calcium and phosphorus absorption. Okay, so that is the function of vitamin D. Okay, so we just looked at the function. Then usually it also helps in mobilization of calcium in conjunction with parathyroid hormone. And its its effect depends on the plasma levels of calcium. So when you have a deficiency of vitamin D, then you end up with rickets. If it's a growing child, you have rickets. But if it is an adult, that decreased mineralization of the bone is called osteomalacia. Now, this deficiency can occur from several sources, either poor sources in the diet or limited exposure to sunlight. So heavily veiled women who do not expose any part of their body can have deficiency states because they are not getting enough sunlight. Or if a child is born to a vitamin D deficient mother, because the baby is breastfeeding, the baby will not get enough vitamin D. Or in a place where the sunlight is very reduced. Okay, so that is what can happen to cause vitamin D deficiency. Now, when there's a deficiency in vitamin D, what happens? It causes a decreased amount of calcium. Bear in mind that the role of vitamin D is to help increase the absorption of calcium and phosphorus from the intestine. So this increased absorption of calcium would lead to deposition in the bone to strengthen the bone or to lead to bone mineralization. So when you have a deficiency of vitamin D, it means that there will also be a low level of calcium. So that is hypocalcemia. Now, when there's hypocalcemia, it triggers the parathyroid gland to produce parathyroid hormone. And the parathyroid hormone will go to the kidneys and activate the hydroxylase, which would cause the production of more vitamin D. That is, if it is present in the skin. Okay. Now, when this happens, then it helps to break down calcium, break down the bone, and free the calcium from the bone. And this would cause a decreased renal excretion of calcium because you don't want to lose the calcium. The calcium level is low. So you go to the bone, you increase how much calcium is taken from the bone, and you go to the kidney and prevent the kidney from losing calcium in the urine. So all these things are an attempt to try and maintain the normal level of calcium in the blood. And so this is what will cause the decreased mineralization of the bone and lead to rickets as a result of vitamin D deficiency. So, yeah. So there are several ways by which this rickets or osteomalacia can occur. I said that the rickets occurs in children, osteomalacia in adults. Now, it can occur when there is one, decreased synthesis of vitamin D in the body. That's decreased endogenous synthesis of vitamin D. How does this occur? If you don't have enough sunlight or you have heavy melanin in your skin, so like us, blacks, then you're at risk of rickets or vitamin D deficiency. Or vitamin D is what is fat soluble. So if you have a problem absorbing fat from your GIT, you can have vitamin D deficiency. So either you are not getting it in your food or you eat it all right, but your bile, your pancreas, or your intestine is dysfunctional, so it's not able to pick it up from the food that you ate. Or it's possible that you have the vitamin D all right, it's present in your blood, but there are certain medications that you are taking alongside which causes increased breakdown of the vitamin D. So here, drug history becomes very, very important. Is a patient on anti-epileptic drugs like phenytoin, phenobarb, or rifampicin? Rifampicin is not an anti-epileptic drug. It's an anti-TB drug. Okay, so if patient is on any of these drugs, know that these drugs are going to cause increased breakdown of vitamin D by cytochrome P450 enzymes in the liver. And so patient is eating enough, but is still having vitamin D deficiency. Or you can have a situation whereby there's impaired synthesis of the vitamin D in the body. Take note of the fact that I said that the vitamin D goes through a cycle. From the skin, it goes to the kidneys and then to the liver. So if there's a liver problem, liver disease, if there's a kidney disease, kidney failure, then you will have problems with vitamin D. Okay, so that's what's explained in point 4 and 5. Then it's also possible that there's no problem anywhere, but when it gets to the target organs that the vitamin D will act on, the vitamin D is meeting a resistance. So that is called vitamin D dependent rickets type 2. It's a congenital lack of the receptors for vitamin D in the bone and then in other parts of the body. Then you can also have a situation where you have a phosphate depletion. So something like if you take antacids, the antacids bind to the phosphate and make it sorry. Okay. Sorry about that. I just got a very funny WhatsApp message. Okay. So let's look at the morphology of rickets. By morphology, I mean, how does it show clinically when a patient comes with rickets? So when a patient has rickets, there will be softening of the bones. And in children, rickets is in children. So you find that the bones of the head will be softened and flattened, and they would be easily, you can actually press it in, and then it can coil back or bounce back, and that's called craniotabes. Then they can have frontal bossing, muma, or they can have rachitic rosary. Oh,
why?
have pictures. I didn't put pictures here because this is pathology.
Yes, madam, but we have to see the type of muma. Because muma is a different type for whole. The exact type.
From vitamin D deficiency. People can also cause that. Then, when you look at their chest, they have this pigeon deformity of the chest, pectus carinatum. Then, because of the movement of the diaphragm in and out, you have a groove formed at the diaphragm area. So those are all things that should help you think of rickets if you see a child with that. Then you realize that the child will have deformities of the spine, the pelvis, and the long bones. And these deformities would lead to a lumbar lordosis. So naturally, we have a lordosis in the lumbar area where it's like the back sort of curves in. You have that increased curvature at the lumbar. No. I'm talking about the lumbar lordosis.
Okay. The bow leg is at the lumbar area.
That lumbar lordosis becomes pronounced. So when the person is standing, it's as if they've pushed their chest forward and they've pushed their butt out more. Okay, that's that I mean. And then they also have bowing of the leg. All these are as a result of the softening of the bones. So this is a child with rickets.
All this while I thought rickets was only legs. No, your forehead is part.
It's all part. There's a whole they have circles, the diaphragm, the ribs, they have rachitic rosary on the ribs and all that. So if I ask you the morphology of rickets, don't just write about bow legs. That's 1 out of 10.
But then that means you ask in the exams.
Maybe.
The way you said it.
I haven't set your questions. I'll do that when I go to Tamale. When I travel.
But the questions will be as difficult as the sun in Tamale. Hey!
In a relaxed atmosphere, while my husband is working, I'll also be sitting behind my laptop setting your questions.
The Nazi.
Nick, when doctor goes to Tamale, some electricals and flow of certain things will happen. So she'll be relaxed and she'll set the question. So it is better she goes to Tamale.
Yeah, I just told you that it depends on my mood. So pray that I have a good mood.
So Christian is counting on the effect of your husband.
Your laughter there.
Madam, if you go with Akosia there, she will disturb your mood.
Oh no. She'll be taken care of. Don't worry. Akosia is the least of my worries. Next time I'm going to bones are already formed, but they become weak when there's rickets, and then they become very brittle, and so they are prone to getting a lot of fractures, what we call pathological fractures. And the fractures mostly affect the vertebral bodies and the femoral necks. Okay, so we've looked at deficiency. Now let's look at toxicity. So if you have excessive vitamin D from the sun, it usually doesn't cause any problem because that's vitamin D that's produced when the sun acts on the skin. It is being converted to 25-hydroxylase by an enzyme in the liver and another enzyme in the kidneys. So if the body has more than it needs, those enzymes will not be activated. So that one is usually not a problem. It is the orally administered ones, the ones that we take in the form of supplements, that is what has the toxic potential to cause problems. Okay, so let's move to vitamin C. Vitamin C, ascorbic acid, it is present in a whole lot of things. It is water soluble. So it's present in a lot of fruits and citrus fruits at that. Now it is useful for hydroxylation of a lot of reactions in the body. And the most important one is conversion of procollagen to collagen. And so this is important when you have wound healing. And that is how come when you have a wound, we say that you should take a lot of vitamin C because it helps with wound healing. Then it also helps with the integrity of collagen at the various mucosal membranes. And that is how come you can have gum bleeding when you have deficiency of vitamin C. It is also an antioxidant, so it can scavenge free radicals and prevent free radical injury to the body. It also acts in concert with vitamin E to help with regeneration of epithelial surfaces. Okay. So when you have a deficiency of vitamin C, you have scurvy. And scurvy usually causes hemorrhages. So hemorrhages, gum bleeding, mucosal bleeding in the mouth, and you can have hematomas or bleeding under the skin in several places in the body. Then it also has an effect on the bone. So it can also cause decreased mineralization of the bone. It can also affect wound healing. So without vitamin C, you can have poor wound healing. And then anemia is also common because of excessive bleeding. Then we know that toxicity doesn't usually occur because it's a water-soluble vitamin, so it usually comes out in the urine. Sometimes the only problem is that it can cause a lot of uric acid to be secreted as well in the urine. The other thing is also that excess vitamin C can also lead to excess absorption of iron, with the potential of causing iron overload. We usually advise patients who are anemic that when they are taking their iron supplements, they should make sure that they take a drink or anything with vitamin C. Or sometimes we prescribe the vitamin C for them, and that helps to absorb the iron. Okay, so this is to demonstrate. So the skin, you can have the petechial bleeding, you can have periosteal bleeding in the joint, and then you can also have gum bleeding as a result of vitamin C deficiency. So we have vitamin E. Please give me a minute. It's fat soluble, and we know that the active form is alpha tocopherol, and it usually helps with the maintenance of the neurons in contact with a mineral called selenium. So when there's a deficiency, you have increased fragility of the red blood cells and breakdown of the red blood cells. So that's what will lead to hemolytic anemia, because it is mainly responsible for the integrity of the neurons. If you have a vitamin E deficiency, you'd have a peripheral neuropathy. So that will manifest as sensation of pins and needles. You can also have a secondary deficiency in premature infants, or infants with fat malabsorption, or people who have a condition called A-beta lipoproteinemia. All these have to do with fat metabolism. Because vitamin E is a fat-soluble vitamin, you can have those problems. So when you have toxicity of vitamin E, it causes a depression of the vitamin K levels, and therefore the enzyme vitamin K activates, like the procoagulants, their levels will also go down. So vitamin K is required for carboxylation of the glutamic acid in several proteins, typically the clotting factors. And so these clotting factors are clotting factor 7, 9, and 10, and actually clotting factor 2 as well. So when we were in school, we had this short form 1972. So the 19 is 10 and 9. So that's factor 10 and factor 9. And then factor 7 and factor 2. So that's 1972. So the clotting factors that are activated by vitamin K is just 1972. Okay. Then it's also required as a cofactor for bone metabolism. It is gotten from either the intestine, from the bacteria flora in the intestine, or from green leafy vegetables. So if you have a deficiency, it is rare actually, because we all have bacteria in our gut. And so once we have the bacteria there, they would cause Akosiayangashina. Go and close the door. Why are you bringing her here, Albert? She wants to come. Doesn't mean you have to bring her. Okay, you go and close the door. So you have that occurring in typically breastfed infants. Oh, Akosiakeba. Oh, give it to me. Give it to me. I don't like that. Oh. Ah. Shame on you. Oh. You see troubles. So yeah, let me explain this point better. Hey, we have 2 minutes. Okay.
Yeah.
So usually the gut contains bacteria, which produce vitamin K, so it's not a problem. However, in newborns, especially those who are breastfed, they have a deficiency of vitamin K because breast milk is a very poor source of vitamin K. And because they are newborns, they are now feeding to generate bacteria in their gut. So the bacteria in their gut haven't really produced actively a lot of vitamin K. And so newborns are at risk of vitamin K deficiency. And this is why when babies are born, they are given an injection of vitamin K. And this is also why when you're taking history in pediatrics, especially if it's a bleeding problem, you need to ask about vitamin K injection during delivery. Then patients who have a fat malabsorption problem. So I said that vitamin K is fat soluble, and so it is in the fat. If you cannot absorb fat from your GIT, it means that you will not be able to absorb vitamin K as well. If you are on broad spectrum antibiotics, you can have a deficiency of vitamin K because the broad spectrum antibiotics will clear the gut of all the bacteria. And so the bacteria which helps to produce the vitamin K will all be killed by the antibiotics you are taking. And for this reason, we usually advise, at least for me in pediatrics, I usually advise mothers that when you are giving your child antibiotic, you should give them a probiotic as well. And usually what I recommend is natural yogurt. Natural yogurt contains a lot of live bacteria, so it helps to regenerate the bacteria in the gut, which is a helpful bacteria which helps to produce some of these things. Okay. Or when you take a large excess of vitamin E or an anticoagulant, then you can have a deficiency of vitamin K. Now, usually deficiency would lead to excessive bleeding or bleeding diathesis. This is because the vitamin K is essential for production of the vitamin K dependent clotting factors. That's the factor 10, 9, 7, and 2. And so without vitamin K, these clotting factors will not be activated. So the patient will bleed excessively. And this commonly is what we call hemorrhagic disease of the newborn.